In this video, we're going to be delving further into the insulin cases that were central to the conviction of Lucy Letby, and particularly the unlikely scenarios that are required in order for these insulin poisonings to have occurred. This is the third video in this series, so I'll just remind people that I've made two previous videos which are here. This is going to be a multiple part series. I think it'll probably run to 10 videos or more, but it'll be somewhere in that ballpark anyway. So it just isn't something that can be dealt with in a couple of hours or a few hours if you're going to do the subject justice, and if you're going to look at all the individual components in the depth that is required. So even at the end of this video, I will not yet have got onto a lot of really important stuff, but that is coming in future videos. The first thing I should remind people, and there's going to be some cross-pollination across these videos, it's kind of inevitable, but I just wish to remind people before we begin that this is a pure hypothesis. The hypothesis involved is that Lucy Letby supposedly poisoned feeding bags on the neonatal unit at the Council of Chester with insulin in order to induce fatal collapses in the infants. Now, as we'll discuss later in this video, the infants didn't actually die. But it's important to emphasise that not only did no one see Lucy Letby do anything wrong, the bags have never been tested, and therefore there is simply no proof that this has occurred. There's not even any evidence to suggest that it's occurred. This is all done on readings. It's all done on, oh, we looked at this and it looked a bit strange. And that's why it all has to be pieced together with the unlikely scenarios that are included in this video, because it is a pure hypothesis. It's a pure invention of the prosecution. It is not something that can be evidentially demonstrated. It is something that they have had to concoct in order to explain how it could be Lucy Letby that poisoned these infants that had slightly strange readings, supposedly with regard to certain elements that can be linked with insulin poisonings. It's not because they tested a bag and found it was full of insulin. It's not because someone saw Lucy Letby acting suspiciously with a needle. It's not because they have any concrete evidence to indicate that there was insulin poisoning. It's just purely because they had to pin this on Lucy Letby. They had to find a way to do it, so they had to come up with essentially an arcane theory in order to achieve this. So I want to begin this video by discussing the fact that the jury in the Lucy Letby case heard from a lot of medical experts. Now, infamously, there weren't any witnesses or experts on the defence side for a variety of reasons, but there were several experts called with regard to these supposed insulin poisonings. And this was one area where the experts were quite definitive in their verdicts. Now, one aspect of this that has been raised to me during my conversations with various people is the notion of the white coat effect, or described here as the white coat syndrome. So the implication of this is that once you get a doctor up there in court, this has an incredible impact on the jury. They just tend to trust doctors, I think not least because it's very difficult for the layperson to question what a doctor is telling them, unless it becomes as ridiculous as some of the things Dr. Evans say. But even under those circumstances, when Dr. Evans, as bad as we now know a lot of the things he said are, and as much as, I made him look like a bit of a pillock in the last video, and lots of other people have done similar things, and as much as his cross-examination is actually really bad. Oh, by the way, I'm not finished with him. There's a lot more. We've only just begun with Dr. Evans. But anyway, as much as all that applies, and as much as all that is pretty much undeniable, it's still a doctor in court. It's still a paediatrician. He still gets cross-examined by the prosecution for a lot of the court case. Half of the time he's on the stand is the and in the witness box is just the prosecution essentially inducing statements from him that make the defendant look guilty. So all the time, the jury are listening to that. They're just hearing the doctor go, and then this is definitely the case, and that is definitely the case. And in the insulin cases, they brought in other experts as well. So this white coat syndrome or white coat effect is known to have a big impact on the way that a jury will perceive things, or indeed that any person will perceive things. We always use this lofty terminology of a jury. Jury is just a load of people picked at random with no particular expertise, and they just sit there and they do the best they can. And I'm sure most jurors do. I'm sure some jurors are terrible as well, but I'm sure most jurors take the job with the due seriousness that it should induce. But I'm sure that some jump to a conclusion, even with the best will in the world. And having doctors in court can be, I don't know if it's unfair to say, if it's fair to say it prejudices a jury, but it can very strongly sway them. So I just wanted to go over some of the key aspects of this white coat effect in court. So the first one is this perceived authority. So it's stated here, experts, particularly doctors, scientists, or forensic specialists, often wear formal attire, use technical language, and present themselves with confidence. This can lead jurors to treat the testimony as more reliable or truthful, regardless of its actual scientific or evidentiary strength. 2. Jury deference. Lay people on juries may lack the specialised knowledge to critically evaluate expert claims, leading them to accept expert opinions at face value. This can skew the fairness of a trial, particularly when expert witnesses are contradictory. Bias and credibility. The appearance of neutrality can mask underlying biases, although there was very little appearance of neutrality in this trial. Experts are typically hired by one side, meaning they may be incentivized to frame evidence favourably to the hiring party, yet jurors might not fully appreciate this adversarial role. Complexity of testimony. When testimony involves highly technical information, jurors may feel overwhelmed and default to trusting the expert's conclusion without understanding how it was reached. And then finally, visual cues and presentation. The way experts present information, charts, diagrams, confident delivery, can increase their persuasive power, again potentially leading to disproportionate influence. All of these 5 points apply to the trial of Lucy Letby to a greater or lesser extent, and to be honest, mostly to a greater extent. You have this, the authority just would apply in any trial, the jury deference would apply in any trial. There was a massive problem with bias and credibility in this trial. I think that's crystal clear. And there's no doubt that this case involved complex medical and scientific information, and it went on for 10 months. I mean, how the hell can the jury possibly understand it all contextually? And then they just hear this doctor, this Welshman, standing on the standing in court going, I'm 100% certain this is the case. This is definitely the case. And half the time they're hearing him, it's just the prosecution just getting these statements out of him that they've essentially prearranged to air in court. And then we know, I mean, it's ironic that they've described a chart here. We know about the shift chart. I'll get on to discussing the statistics in future videos. I've touched upon them in previous videos, but they did use charts to try precisely to do that, to try to sway the jury. It's described here as persuasive power. And of course, very confident delivery. Like Dr. Evans believes he's right about everything. I actually wouldn't describe his delivery in court here as particularly confident, because when he was cross-examined, he was really poor. But that might not be enough, particularly in the absence of witnesses for the opposing side and in Lucy's favour. So I've also asked a question here. If an expert is unduly confident and bombastic in court, could this exacerbate the known white coat effect? Yes, an expert who is unduly confident and bombastic in court could exacerbate the white coat effect, particularly in how their testimony is perceived by the jury or judge. 1. White coat effect, broad understanding. Traditionally, the white coat effect refers to patients exhibiting elevated blood pressure in clinical settings. So that just explains something we already know. There's no need to read that. Expert authority and psychological impact. In court, experts are already endowed with a certain level of epistemic authority. Epistemic authority, I should say. When an expert behaves with overconfidence, certainty, and bombast, it can amplify their perceived credibility to those who equate confidence with competence. suppress critical scrutiny by jurors who may feel intellectually outmatched or deferential, drown out opposing viewpoints, especially if the counter-expert is more measured or modest. So already, these are all problems we had with Dr. Evans. So he would give these very definitive statements. This baby was absolutely fine, then it collapsed. I'm absolutely certain. There's no other possible explanation, etc., etc. And I think as well we saw a more modest performance from Ben Myers compared to Nick Johnson. Now, I wasn't in court, but I know people that have seen them both extensively, and it's known that Nick Johnson presents in a much more forceful way. He also had the luxury of being the prosecution. It's very difficult for people to go on for the defence to be too forceful, because they're defending a murder and they can't come across as in the wrong way, as aggressive or belligerent. So I think Ben Myers, in his defence, had a much harder job. You know, I've been critical of him and some of the things that the defence did. Possibly some of that is due to the solicitor, not just the barrister. I also think he did some good things, but I think we must acknowledge that he had a much harder job. Now, in this case, the opposing experts can't be drowned out, but the defence can be drowned out, and I think to a great extent it was. And in the Insulin cases, there's not only Dr. Evans, there's Hindmarsh as well, and he was very definitive. Others got on the stand and were very definitive. It was really presented to the juries if there's just no other possible explanation. There have to have been insulin poisonings. It has to have been Lucy Letby. Our hypothesis that we've just pulled out of the ether, essentially, that's the only possible explanation. And then, you know, you see here the consequence of this, that there can be cognitive biases in the jury. Jurors may give more weight to the expert's opinion. They can mistake the confidence of someone for truthfulness and accuracy. God knows, Lord only knows that we know that's not true. There's the anchoring effect, where a forcefully delivered opinion may anchor the jury's perception of the truth, even if it's flawed. There's the potential for it to backfire here, but I think with Dr. Evans, he's the perfect combination of being really unthreatening and kind of almost diffident. Like, his manner is very, very mild. It's particularly mild. You know, he seems very avuncular and very unthreatening. It's the complete opposite from what I would have expected as an expert witness, but now I can see why he's been so successful, because he always comes down hard on the side that he's supposed to be working for, and then he doesn't do it in a threatening way. He does it in quite a gentle way. So it's stated here that this can backfire if the expert is perceived as arrogant or dismissive, but he may not have appeared that way. In a way, it might have appeared to the jury that Ben Myers was being horrible to him, and that Ben Myers was just nitpicking when they'd heard all this nice evidence, this nice, clean, easily understandable evidence from the prosecution that there's definitely been insulin poisoning, and then Ben Myers comes along and tries to muddy the waters and nitpick and stuff to this elderly Welsh gentleman who's just there trying to help, you know. So I don't think... So this can really be ruled out in this case. I'd say, if anything, the nature of Dr. Evans and the way that he speaks probably acted in his favour. But anyway, regardless of that, if you go into... It's stated here, and I believe this is undeniable, that if you are overly confident... I've used the word bombastic, because I think a lot of the claims made were bombastic. Then it can intensify the white coat effect, leaving jurors to overvalue the testimony based on perceived authority rather than merit. It's stated here it's a double-edged sword that can be strategically challenged, and I think Ben Myers did a reasonably good job of doing that, but clearly he wasn't successful. So before we even consider the insulin cases, it's important to remember these two things: the hypothetical nature of them, the fact there's no proof and it is a pure hypothesis, and also that there was this enormous white coat effect influencing the way that the jury perceived things, because so many experts and so many people relate to the laboratory as well. Not just doctors, not just Hindmarsh, not just Evans, not just Bohin, not just hematologist Sally Kinsey, I think, gave evidence in relation to this. But also they had people from the labs as well, and all the people from the lab said, oh, you know, they said ridiculous things, as we'll get onto in future videos, but they had all these experts lining up against them, And this, in my view, definitely amplified the white coat effect that we've discussed here. During the research for the book that I've written, I spoke to an expert on juries who had written her PhD on this topic. She actually very kindly gave me a PhD. I haven't used any of it in this video because I didn't ask for her permission. But she told me that another aspect of this phenomenon is that experts may not introduce problems with evidence, so they might not refer to error rates, they might not look at the limitation of tests, they might not interpret tests in a way that is unfavourable to one side or the other, or perhaps the organisation or institution which they're representing. That will become relevant in future videos. They don't assess the qualifications of the people administrating these tests, or perhaps the quality of the laboratories that are performing them. A lot of very important context actually goes missing, and this was a court case in which an enormous amount of context was just never heard by the jury. And this just amplified this effect that we're talking about even further. It was almost off the chart in this trial. And I think there's no aspect of it where this is more relevant than with regard to the insulin cases. It's also fair to say that Lucy received some pretty poor counsel from her solicitor in accepting the assertion that insulin poisoning had definitely occurred. And this is kind of backed up by the fact that there's been forensic examination of Lucy's life, and there's no evidence of her ever previously taken interest in insulin. Now, I suppose that insulin poisonings are less obscure than the embolism cases and some of the other bizarre things that she's accused of having done. But if she was, as we'll see, if she was attempting to poison infants with insulin, she's done it extremely badly. So her knowledge of the subject must have been pretty bad if she'd attempted to do this. Of course, a much more obvious explanation, as we'll see across all these videos, is that there were natural explanations for the readings that were seen in these infants, and there were no insulin poisonings. And it is a hypothesis that is just simply plain wrong. In a previous video, I discussed the theory of sticky insulin. Now, there is overlap in some of these videos because various aspects of the insulin cases feed into several subject areas. So I just want to revisit sticky insulin briefly because it is one of the unlikely scenarios that is involved in these supposed poisonings. So particularly in the case of child L, there were two children that were allegedly poisoned with insulin, child F and child L. And in the case of child L, Professor Peter Hindmarsh, who I've mentioned already, he came up with this amazing theory of sticky insulin to explain irregularities that otherwise couldn't be explained. He asserted, again, this is completely hypothetical, naturally, that insulin that had been previously administered via dextrose infusion somehow became stuck to the inside of the apparatus and then somehow became unstuck when Lucy went off shift, so that insulin continued to find its way into the system of child L in a way that was observable in this baby. This theory had to be concocted because the hospital used bags with varying dextrose percentages, which had to be mixed by the pharmacist before arriving on the ward, and this meant it was impossible for Lucy to spike them in advance. So the existence of this theory is not because this is a really useful piece of science that explains something that we don't understand. It's just there because otherwise the prosecution case makes no sense. It's a pretty fanciful notion. And again, there's additional reasons why it needed to be used in the court case. Child L had experienced hypoglycemia, which is low blood sugar, in the absence of Lucy. while having received a new bag straight from the pharmacy that we know Lucy had never had any contact with whatsoever. So it was necessary to employ this theory in order to explain certain phenomena associated with the infants. However, at other times, the prosecution did not cite sticky insulin. So it's quite similar to, for example, they would say, "Oh, we know you're in this room, Lucy, because of the swipe card data." But then when Lucy said, "Well, we know I'm not in that room because of swipe card data," Nick Johnson just said, "Oh, but you could have sneaked in behind someone else." As I mentioned previously, that's just one example. There are many others. I should mention in this case as well, child F was hypoglycemic, suffering with low blood sugar for 17 hours. So if there's a sticky insulin theory, we would expect, even if that had occurred, which is again is completely unproven, there's no even evidence to suggest this happened. It could theoretically happen, but it's just a pure hypothesis yet again. But the theory is that if this occurred over such an extended period of time, the amount of insulin in the feeding bag would become unavailable, as the amount of insulin also reduced over time as more of it became stuck to the inside of the bag. This was discussed in court. It wasn't even disagreed with. I mean, Hindmarsh accepted this, but it's not consistent because readings for child F were notably stable throughout the day, just immediately contradicting the so-called sticky insulin theory. So it's a pretty dubious theory. It's pretty contrived. It is necessary in order to make this hypothetical case even remotely work, which is why it's been brought forward and why they've brought it into play, because otherwise they can't say, because they don't have the bag, they don't have any eyewitness accounts, they don't have any proper measurements, they don't have good testing. So there are all kinds of problems with the insulin cases. So they've had to really cobble something together just to try and get them over the line. You know, credit to them, they've been successful in this incredibly one-sided, chronically unfair and unsound court case and court procedure. But when you look at the actual science, I mean, it's really poor, again. So during my research on the insulin cases, one insulin expert mentioned to me that the figures used in court are pretty dubious. Professor Hindmarsh had estimated that 10 units of insulin would be sufficient to contaminate the intravenous infusion bags, but this corresponded to only 0.1 millilitres of this substance called actrapid. I believe you'd pronounce it. You can see it on the screen now. And I was told that this is a very tiny amount of insulin indeed, and that it just doesn't make any sense because a perpetrator would seek to inject more insulin into the bags of dextrose if they were attempting to poison the infants in order to make their attack more likely to be successful. Indeed, this supposed attack, was not successful because both of the infants survived. And the notion of administering this medicinal insulin, so it's important to note this is medicinal to begin with, in such a diluted dosage form, 0.1 millilitres diluted into 500 millilitres, compared with intramuscular injection of actrapid taken from the vial, would probably not be pharmacologically active. Again, this is something that hasn't been tested. It hasn't been confirmed to be the case in the real world. And again, no experimental testing has ever been conducted on anything that was asserted in court, and certainly not with regard to the insulin cases. I'll just mention that pharmacologically active means having a measurable effect on living matter, particularly in the context of drugs and medicine. It refers to the ability of a substance, such as a drug or its metabolite, to produce a beneficial or adverse effect on an organism. So the argument here that the insulin is not pharmacologically active indicates in the dosage indicated, it just may have no effect. So you can see on the screen here that the key determinant of activity with regards to the allegations made is the total number of insulin units administered, is not just the concentration of that dosage. But if the infusion rate is too slow or the total volume isn't fully delivered, the patient may receive subtherapeutic doses over time and the effect may be minimal. Or in this case, it's not subtherapeutic doses, it is a dose below the level that would need to be induced in order to achieve the poisoning effect that was alleged. So you can see here as well that experimental testing is critical in chemistry. It's used to validate theories and hypotheses, discover new phenomena, determine the properties of substances, understand reaction mechanisms, develop and optimize processes, ensure accuracy and reproducibility, and apply chemistry to real-world problems. Experimental testing is central to chemistry as a science. It turns theoretical ideas into verifiable knowledge. So that's absolutely critical. So without engaging in experimental testing on this scenario that's occurred in these supposed insulin poisonings, you cannot verify. They're not verifiable. It's just a theory that the prosecution has come up with. Again, a hypothesis that has not been determined in any meaningful way. So that's why you see here on the screen, this is a question given to me by a doctor for Dr. Evans. Once he gives you his diagnostic criteria, ask how he validated it, how does he know it actually works? And this very much applies to this notion of experimental testing, although this would not have been a chemical or chemistry related issue, but it's the same principle. So on the screen now is Dr. Richard Taylor. He was speaking here at a press conference related to Lucy Letby's appeal on the 16th of December last year, 2024. He cited glucose readings from the Countess of Chester as being not only significant but extraordinary. He said what was missed was an incredibly high blood glucose value, and that was completely inconsistent with the clinical findings on this baby, where bedside glucometer measurements were extremely low. And yet the blood sample which was used to analyse the insulin actually read 999 millimoles per litre glucose. So this 999 millimoles per litre is just a standard measurement in chemistry that's used with regard to glucose and various other substances. Dr. Taylor explained that this meant that glucose had been definitively flagged as being high, and this was verified information that appears never to have come up in court. It was never even mentioned in court. That's significant in itself, but the 999 reading is a major bone of contention in this case. It's pretty much universally accepted. I can't imagine anyone could possibly disagree with it, that this reading is extraordinarily high. I mean, essentially it is as high as the machine can possibly go, yet this was not revealed in court, it was not discussed in court, it was not contextualised in court, it was not mentioned at any point during the court proceedings that 999 is stupendously high. And so with regard to this, it's been suggested by numerous people that I've spoken to that this reading could be an error code indicating a quantity that is above the maximum level that is measurable by laboratory equipment. So as soon as I did some basic research on this 999 reading, immediately I was told, I just simply Googled, as you can see, the number, and just immediately told this is not a valid blood glucose reading. Blood glucose meters typically display a reading of 999 or ERR when the glucose level is above the maximum value they can measure. This indicates that the blood glucose level is extremely high and potentially dangerous. This is just something that is not flagged at all in the court case, and it indicates that all of the results related to the insulin cases become highly suspect, and the whole clinical picture that is presented in court becomes equally suspect. Again, I just did a little bit of research here. I didn't even properly contextualise what I was saying. I just typed in the number, and then ChatGPT says a glucose reading of 999 millimoles per litre is extremely high and not physiologically possible in a living person. It likely indicates one of the following: unit error, meter error, or malfunction, which is over. And I don't think it's even necessarily so much an error. It's just that there's so much. It's like, well, it is possible it's a malfunction. Either the equipment that's being used has broken at that moment, or the amount being read has just gone beyond the level that it can read, in which case it's not an error as such, it's just limitations of the laboratory equipment. It does seem quite possible that it's a malfunction and that the glucose levels were never this high, and there's just been some sort of problem and it's been not understood by people in the laboratory and they've written it down and never thought about it again. But it seems it's almost infinitesimally unlikely that this is a legitimate reading that is correct. It's almost certainly wrong. It's almost certainly indicative of an error of some sort, either just the limitation of the laboratory equipment or, as is suggested here, a possible malfunction. Even if you change the unit of measurement to a different unit of measurement, it's still described as an incredibly, unbelievably high reading. But in the actual measurement related to this case, it's extraordinarily high to the point of being implausible. In fact, as we see here in this BBC article that was published during the trial in November 2022, all of the levels that we saw in this court case were astonishing. We were seeing astonishingly high levels across the board, which again calls into question the accuracy of the measurements. We're going to go into the testing and all the problems with the testing, all the problems with the readings in later videos. But even the readings that were recorded and written down, even before you look at any of the other problems, pharmacological, biological, and chemical problems, even just the readings themselves just seem highly dubious, and it's doubtful that they're correct, particularly obviously the glucose reading, that it just, you can say almost there's certainty that it's not correct. One possible explanation for this is that Child F had very high levels of glucose in his blood, indicating hyperglycemia, high blood sugar, rather than hypoglycemia, low blood sugar. It's quite possible that the heel prick tests that were conducted on Child F were incorrect, indicating that the child was hypoglycemic, suffering with low blood sugar, and the infant was thus given too much glucose, resulting in these readings, which experts agree unanimously is an enormously high figure. So you can see on your screen now the definition of a heel prick test. This is just a blood test performed on newborn infants to screen for rare but serious medical conditions. As the name would suggest, a healthcare professional will prick the heel of the baby, collecting a small blood sample, which is then sent for laboratory analysis to detect any potential health issues. So this is why Richard Taylor has said during the press conference that the readings with regards to these infants is so high that it's off the scale. He described it as ridiculously high, stupidly high. We have two stupidly high numbers, the high insulin number, which was the one that the experts focused on, and the high glucose, which was completely ignored. And then Dr. Taylor explained that the high glucose number could be a misprint. It could be that the lab machine broke and churned out some number that doesn't fit very well. And he also went on to speak about contamination. Now, while contamination is a possibility, and while far be it from me to question a neonatologist or suggest that I would know better, that clearly that's not the case. And you can't rule out contamination completely, but certainly people I've spoken to indicate that this is far more likely to be a machine error, as he also suggested. and it seems that there would need to be an extraordinary amount of contamination to account for these figures. There have been efforts made to contact the manufacturer of the machine that read glucose and indeed other substances at the Council of Chester, but naturally they've not been particularly forthcoming with information that might make their company appear incompetent. I don't think anyone should make that accusation. I'm sure the laboratory equipment is very good. There can be problems with the best equipment in the world. Ultimately, the reason there's an error code is to indicate that there's an error, and the failing really would be on behalf of the people that didn't understand this error code and don't know how to use the equipment. So this led Dr. Taylor to state that there was no compelling evidence of murder. The evidence that was provided was instead compelling evidence of bad testing. So I'd like to spend a little bit of time to go into the background of child F, because this was, again, another infant in the case that had numerous chronic health problems, and looking at the picture of this child gives a better indication of the complications that occurred with regard to his blood sugar levels and so forth. So child F was born at 29 weeks, meaning it was yet another premature child born at a low body weight with a heightened risk of health complications and premature death. This is yet another infant in the case that was resuscitated at birth, and because this child was a twin with child E, it was also, this is something that wasn't mentioned very much, if at all, in the court case. Twins and triplets are considerably more vulnerable than children born as a solitary infant. And as a consequence of being a twin, child F was born with this condition referred to as monochorionic pregnancy, where two children share one placenta in the womb. This can lead to placental deficits, threatening the growth and survival of both infants. Indeed, we know that child E unfortunately didn't make it. I've been through the details of child E in a previous video, but I'll definitely be going into that in more depth in the future. So child F is one of two infants that Lucy is accused of poisoning with insulin. And so it's therefore notable that infants were prescribed insulin days before the alleged events took place. In fact, the aforementioned child E, who is the twin of child F, was prescribed and receiving insulin at the time of these supposed poisonings. There were problems with blood glucose measures, as we've mentioned, in both child F and child L, but they were shown to be particularly errant in the case of child F when two measures were taken merely 4 minutes apart. They were errant by 30%, indicating that, yet again, testing on the unit was failing. This was at a time that is completely unrelated to any even alleged attacks by Lucy Letby, so it demonstrates a pattern of the unit being unable to adequately measure critical aspects of these infants' kind of anatomical picture. It also demonstrated that there was variability to the blood sugar checks that were conducted on the unit, depending on what's referred to as the poke that was taken on the neonatal unit. There's also a variation of approximately 15%, depending on whether blood sugar was checked on the unit via meter or in laboratory conditions. So all of these variations, they can lead to bad decisions. It can also lead to errors, and it can lead to us not getting a full picture regarding exactly what was occurring with these infants. Child F received 5 D10 boluses of glucose during the 17 hours when the infant was reported to be suffering with hypoglycemia. I'll be returning to the topic of boluses later in this video. Evidence-based practice, I've been told by a neonatal nurse who is an expert practitioner, is that only one of these boluses should be given before changing the approach. This is for safety reasons, and this obviously hasn't occurred. They just decided, let's just carry on with the boluses. This is actually was also mentioned by the panel. We'll be going over that information later in this video. The glucose infusion rate, which measures the exact amount of glucose the infant was receiving, was not increased by the required amount with each low blood sugar, as is required by evidence-based practice. There's also a risk in child F of falsely elevated levels of insulin due to the infant being on lipids, which are fats used in the treatment of infants, and heparin, which is an anticoagulant medication used to treat blood clots. So to reiterate, child F was premature, low birth weight, significantly high risk. The mother endured a complicated pregnancy. The infants were diagnosed with twin-to-twin transfusion syndrome, a rare condition which occurs when identical twins share the placenta and grow unevenly. There was a reception of the infusion of insulin from child E due to associated nutrient deficiencies. This could have had a knock-on effect on child F. Child F had respiratory distress syndrome and hyperglycemia requiring insulin treatment, developed sepsis, and actually fluctuate between hyperglycemia and hypoglycemia during the early hours of his existence. This has led neonatal experts, including both and insulin experts that I've interviewed, to question whether insulin administration could possibly have been involved in this case, particularly considering that the blood sugar of child F didn't continue to drop after receiving insulin through when there was no dextrose running, and why this infant did not experience further complications and symptoms of severe hypoglycemia based on the data that is publicly available. So there's lots of complicated information there and a lot of medical conditions and jargon. I think there are essentially two key points. Three. The first is that the medical picture of this infant was such that there could simply be naturally occurring phenomena that accounted for the problems that the child anticipated. The second thing is that the quality of testing on the unit was such that a completely misleading impression of what actually occurred with this infant can easily be garnered, and then communicated in court. And I think also it's not merely the testing, it's also the quality of processes that occurred in this unit. And then the third thing is that there's lots of data pointing to the conclusions and hypotheses of experts that appeared in court during Lucy's trial being completely wrong, and that there are other explanations that are actually far more logical and plausible. So the panel of international experts that's been convened by Mark MacDonald and Dr. Xu Li have studied, as we know, all of the infants and their cases, and they concluded in the case of child F that the hypoglycemia of this infant began with sepsis and prolonged over a period of time because the IV bag of the infant became infiltrated for several hours. Hypoglycemia persisted, as is known to be the case, and experts that assessed the case were critical of the fact that a higher infusion of glucose was required than that which was provided. The panel also provided a lot of very technical information related to the infusion of dextrose that I'm not going to go into. And they also pointed out that since infusion bags were prepared in the pharmacy, stored in the unit and changed at 1200 hours, multiple infusion bags would need to be contaminated if there was insulin poisoning. The blood sugar rose after 1900 hours, not because the infusion bag was changed, but because the dextrose was increased to 15%. They further reported that glucose levels should be lower if exogenous insulin was used, and that the insulin C-peptide ratio was within the expected range for preterm infants. We're getting into that aspect of the case in previous videos, in future videos. This is obviously the third video in the series. there's already quite a lot of information in these first 3 videos, but there's a lot more to come on various subjects. The panel also noted that insulin autoimmune antibodies, which are common in preterm infants, bind to insulin and increase measured insulin levels. So what they're essentially saying there is that the specific biological and anatomical characteristics of preterm infants contributes to the likelihood that they will have unusual insulin readings. So I just want to go over this final statement there made by the panel before we go into some more background related to these infants. So I've asked this question: in certain preterm infants, particularly those with maternal diabetes or prior insulin exposure, insulin autoantibodies may be present and combine to insulin. This binding can interfere with some immunoassays, resulting in falsely elevated measured insulin levels. Is this an accurate statement? Yes, your statement is accurate and reflects a clinically recognised phenomenon. Here's a breakdown of the key points. Preterm infants and maternal diabetes. In infants born to mothers with diabetes, maternal insulin autoantibodies can cross the placenta. Additionally, if the mother was treated with exogenous insulin, especially animal-derived insulin, these antibodies may be more prevalent. Insulin autoantibodies. These are antibodies that bind to insulin. In neonates, the presence of these antibodies is typically passive, transferred from the mother, rather than produced by the infant. Effect on immunoassays. Many insulin immunoassays can be interfered with by insulin autoantibodies, which bind to insulin and form complexes. These complexes may be detected by certain assay formats, especially those that don't adequately dissociate the antibody-insulin complexes, result in falsely elevated insulin levels due to the detection of insulin bound to antibodies or altered assay kinetics. Clinical implications. Misinterpretation of insulin levels can complicate the evaluation of neonatal hypoglycemia or hypoinsulinemia, potentially leading to incorrect diagnoses or management decisions. In summary, yes, maternal insulin autoantibodies in certain preterm infants can interfere with insulin immunoassays, leading to falsely elevated insulin measurements, particularly if the assay is not designed to account for such interference. We're going to get into the immunoassays. This was the method of measurement that was used in these cases. This is going to be assessed and discussed in some depth in a future video. But the point here is simply that the assertion by the panel is very much medically and scientifically supported. Now, there's a lot of pretty complicated science that's been provided by the panel, even its preliminary report that's been circulated publicly, let alone the enormously detailed full report that's now been submitted to the Criminal Cases Review Commission. But I'm going to summarise some of the key points in this section. The first of these is that child F suffered with prolonged hyperglycemia due to sepsis, prematurity, borderline intrauterine growth restriction, lack of intravenous glucose when its long line was infiltrated for a prolonged period of several hours, and poor medical management of hypoglycemia. I'll just explain briefly that intrauterine growth restriction, sometimes known as fetal growth restriction, is a condition where the fetus is smaller than it should be for its gestational age, meaning that it's not growing at the expected rate. It's not always a particularly serious condition, but if there are other health issues as well, if it's a premature infant, it can be a serious complicating factor. The next point is that the insulin level and ratio-related C-peptide are within the normal range for preterm infants. As I mentioned, we're going to be discussing C-peptide, which is an aspect of the insulin measurements conducted by the Council Chester in the next video that's going to be discussed. Extensive swelling and induration refers to the thickening and hardening of body tissue, was noted, indicating that infiltration had endured for a considerable period of time. Errors were made with IV lines, which meant that child F did not receive adequate sugar. Child F also didn't receive dextrose for several hours, which is the likely reason for its hypoglycemic state. Mistakes were also made with regard to the injection of boluses, which compounded the situation. This resulted in what Dr. Lee termed a yo-yo pattern of rising and declining blood sugar. Dr. Lee also described the mistakes made on the unit as a very basic thing and that we teach all medical students not to do this. I should just confirm that a bolus is essentially a small concentrated dosage of medicine, very rarely used in any other context. The document relates to the panel also discusses the rather implausible logistical scenario that I've covered in a previous video that is required for the feeding bags on the unit to have been deliberately poisoned. In order for this baby to have had insulin introduced into the bag, it would have had to have been done multiple times into multiple bags. It should be added that Lucy wasn't even on duty when the feeding bags were hung out for the infants on the unit. It is noted that if all of the information available for child F is used, a very different conclusion to that presented in court is inevitable, according to the panel. Additionally, the fact that child F was being treated for sepsis was also discussed in the preliminary report of the panel at some considerable length. As has been established already on this channel, and it's something that has been extensively documented by numerous sources, sepsis was essentially endemic on this unit, present in 9 of the 17 infants from the court case. The fact that sepsis could be a factor in the clinical outlook for child F was certainly not a secret as well. For example, Dr. Philip Hammond told the John Sweeney podcast that abnormally high insulin results may partly have been due to the fact that one of the babies was septic. There's a lot of cross-reaction when you do this particular test, and it's possible that this artificially raised the results. So I'm not going to go into the immunoassays and testing in great detail in this video because that's going to be the subject of a future video. But you can see here that there's some information on cross-reactivity and immunoassays, which is well known to be the case and which has been referenced here by the panel. The phenomenon related to sepsis and hypoglycemia is also extensively documented in academic work. For example, a Japanese study from 2022 discusses the relationship between sepsis and hypoglycemia, and another paper published in the American Journal of the Medical Sciences notes that several studies have reported that insulin levels are increased in patients with sepsis and septic shock. This is commonly known anyway, and it's in no way contentious or even disputable. There is also support for an immediate change in insulin sensitivity that varies over the first several days in patients with sepsis. There have also been parental links with diabetes for child F in particular, and it is known that this can contribute to an uncoupling of insulin and C-peptide levels. Medics that I spoke with informed me that if a mother of an infant develops diabetes during pregnancy, referred to as gestational diabetes, and is treated with insulin, this can easily be passed along to the baby via its placenta. It's also, of course, notable that both infants survived in this case, and part of the reason for that is that if this had been a deliberate poisoning, which is unbelievably unlikely, it's a particularly inept attempt. So I've met with one insulin expert in particular. I won't mention the name of that person at this point in time, but I've had very extensive conversations with him, and I've communicated with others. And they have said to me that essentially the court case requires a series of increasingly ridiculous scenarios in order to assert that Lucy Letby is guilty, and that these are essentially fundamentally flawed. And that what should really have occurred is that they should have begun with the most provable scenario and the most probable scenario, not begin with poisoning as a hypothesis and then make arcane attempts to prove it, which are unsupported by actual evidence or any reasonable scientific or chemical analysis. It's also bemusing that a person would deliver what is supposed to be a poison, in this case insulin, and then mix that together with glucose, which is effectively the antidote to that poison. And as I say, all of these experts that I've spoken to have said that what's asserted in the court case doesn't make any sense. It wouldn't make any sense in isolation, but bear in mind, Lucy Letby has already supposedly attacked babies with air. She's already supposedly attacked babies with milk and been successful. Then she starts using insulin. Then it's unsuccessful. Then she goes back to these other methods. They're successful again. Then she goes back to insulin. Then it's unsuccessful. Then she goes back. Come on, there's no way. It's absolutely ridiculous. And then she's also, on top of that, on top of the logistical problems, the chemical plausibility, the fact that it's injected into the bags, and then the bags contain glucose. Aside from the fact she doesn't know which bags to contaminate, aside from all these problems, there's also then very small amounts being diluted highly while administering the substance into something that will counteract the insulin. But because they've gone down this improbable route of deciding that Lucy Letby must be responsible for everything that has occurred on this unit, they have to keep piling these absurdities on top of each other to the point where it just becomes absolutely ridiculous. And yet, the insulin cases are the most solid cases in court. This is the best evidence that was involved in the court case, the best science. The other cases are absolutely ridiculous. So the interactivity between insulin and glucose is well established, but I want to go over this anyway, just to make this crystal clear. So I simply ask this question of, can glucose counteract the effects of excessive insulin? Yes, glucose can counteract the effects of excessive insulin, and in fact this is exactly how hyperglycaemia, low blood sugar caused by too much insulin, is typically treated. Here's how it works. Excessive insulin lowers blood glucose levels by promoting uptake of glucose into cells and inhibiting glucose production by the liver. When there's too much insulin, blood sugar can drop to dangerously low levels, which is the condition of hypoglycemia. Administering glucose either orally or intravenously raises blood glucose levels, countering the effect of insulin. Treatment scenarios. Mild hypoglycemia requires, as is suggested here, like fast-acting carbohydrates such as glucose tablets, and severe hypoglycemia would require, as was used in the Letby case, intravenous dextrose. Or the other option would be glucagon injection, which stimulates the liver to release glucose. So this outlines that what has been asserted by the experts, and it also relates to the overall clinical picture of the infant, in that it's just very likely that the issues that were detected by these readings simply relate to very naturally occurring hypoglycemia, rather than the injection of insulin, which, as has been stated previously, requires this rather far-fetched, frankly ludicrous scenario. And also there's numerous problems with it, because even the sticky insulin theory that's required in one of the cases doesn't really match up with the figures. So it's just probable, very likely, overwhelmingly likely, that this is a case of naturally occurring hyperglycemia. It's certainly not proven beyond reasonable doubt that Lucy Letby injected insulin into these bags, even based on what we're looking at now. But there's going to be a lot more information in the videos to come that will call these conclusions into even greater question. And then to reiterate, both of these infants survived, of course. Again, questioning why Lucy Letby would attempt these arcane acts under the circumstances when she supposedly already harmed infants with air, although that's absolutely ludicrous. So talking about the use of glucose on the unit, Dr. Shu Lee also pointed out, in relation to child F, that insulin had been administered in the wrong fashion via repeated boluses that was mentioned previously, essentially could be considered similar to large tablets, rather than by titrated continuous infusion in a careful way. As a reflection of this, when child F was tested and low readings were discovered, further boluses were injected with less than 2 hours between each dose, described as very frequent by Dr. Lee. The conclusion of insulin experts and neonatologists that worked on the case for Letby's appeal was that the manner of glucose provided would cause insulin surges, and that all records indicate that the blood sugar of this infant was rising because intravenous infusions were stopped. So there is a lot of quite complex information in this video. So I'm going to go over everything that's been discussed and summarise it. So to begin, Lucy Letby has been accused of poisoning infants at the County Chester Hospital with insulin, but the prosecution case intended to support this allegation is entirely hypothetical. No one saw Lucy Letby engage in any poisoning, and none of the bags that she supposedly spiked were ever tested. Discussion of the insulin cases in court is highly likely to have been influenced by the white coat effect, whereby the word of doctors is given credence beyond its actual reliability or credibility. This is particularly true due to the conduct of certain expert witnesses during the court case, obviously Dr. Evans in particular. There is no evidence of Lucy Letby having researched insulin in any way or having demonstrated an unhealthy interest in the subject. The prosecution case also relies on the highly fanciful sticky insulin theory, which isn't even consistent with the observed characteristics of the infants. It is notable that the prosecution case requires Lucy Letby to administer very small amounts of insulin into diluted solutions, and that this was also administered to bags containing glucose, which would counteract the insulin. This would make the whole poisoning scenario, at best, an extremely inept act, but more likely implausible and something that didn't occur. One must also question why Lucy Letby has suddenly begun using insulin when having supposedly previously been successful with air. An insulin expert that I spoke with doubted that the method alleged by the prosecution was pharmacologically active, and also pointed to the fact that it had not been experimentally tested. It was therefore, in common with all of the prosecution case, entirely hypothetical. A 999 glucose reading that was not even discussed in court is so extraordinarily high as to be completely implausible. It seems certain that this is an errant reading. This has all manner of consequences for the clinical picture associated with the infants, and indeed for the calibre of testing on the neonatal unit more broadly. It seems that one of the infants involved in the case had been given too much glucose by the hospital due to a misinterpretation of the infant's condition. Child F was suffering with an array of health complications, several of which were related to a placental deficiency caused by the fact that the infant had to share a placenta with his twin. Child F is also one of many babies in the case suffering with sepsis. This is significant as sepsis can help to explain some of the phenomena observed in the court case. A panel of international experts convened by Dr. Shuley to study cases concluded that the hypoglycemia of Child F began with sepsis was prolonged because the infant's IV bag infiltrated for several hours. There is also evidence of several medical mistakes being made by the Counsellor Chester in the care of these infants, including using an incorrect methodology for administering glucose. This resulted in what Dr. Lee termed a yo-yo pattern of rising and declining blood sugar. Dr. Lee also described the mistakes made on the unit as a very basic thing, and that we teach all medical students not to do this. There are major logistical issues related to the bags and alleged poisonings, which makes the supposed poisonings illogical and highly unlikely. Several experts affiliated with barrister Mark McDonald's panel of international experts reported that glucose levels should be lower if exogenous insulin was used, but the insulin C-peptide ratio was within the expected range for preterm infants. This issue will be discussed in greater depth in forthcoming videos. The experts also noted that insulin autoimmune antibodies, which are common in preterm infants, bind to insulin and increase measured insulin levels, a potential factor in these supposedly unusual readings. Child F suffered with prolonged hypoglycemia due to sepsis, prematurity, borderline intrauterine growth restriction, lack of intravenous glucose when the long line infiltrated for a prolonged period of several hours, and poor medical management of hypoglycemia. The fact that Child F was being treated for sepsis was discussed at some length. As has been established in previous videos, sepsis was endemic on the unit over the period of Letby's alleged crimes. Several experts cited potential issues with cross-reactivity and the method of testing utilised, which is a commonly known phenomenon. This will be discussed in considerable depth in future videos. Extensive swelling and induration, thickening and hardening of body tissue was noted, indicating that infiltration had endured for a considerable period of time. Errors were made with IV lines, which meant that Child F did not really receive adequate sugar. Child F did not receive dextrose for several hours, which is the likely reason for the hypoglycemic state of the infant. There have also been parental links with diabetes for Child F in particular, and it is known that this can contribute to an uncoupling of insulin and C-peptide levels. Medics that I spoke with informed me that if the mother of an infant develops diabetes during pregnancy, referred to as gestational diabetes, and is treated with insulin, this can easily be passed along to the baby via its placenta. One expert that I spoke with was critical of the court case, citing increasingly ridiculous scenarios in order to assert that Letby was guilty. You should always start with the most probable scenario, not begin with poisoning as a hypothesis and then make these arcane attempts to prove it, which are unsupported by actual evidence. The supposed poisoning is also particularly inept, not least because insulin would have been infused into bags already containing glucose, which would essentially counteract the chemical impact of insulin. The conclusion of insulin experts and neonatologists that have worked on the case for Letby's appeal was that the manner of glucose provided would cause insulin surges, and that all records indicate that the blood sugar of this infant was rising because intravenous infusions were stopped. Finally, despite some extraordinarily and highly implausible readings being recorded on the unit, both infants survived the supposed insulin poisonings. So I want to finish this video just by stating that this wouldn't be possible without the support of many people that I've spoken with, chemists, doctors, and nurses. I would not be able to produce this video on my own. So I find it kind of hilarious when I see people who wish to claim that Lucy Letby is guilty writing articles off their own bat with no scientific qualifications, with no medical expertise, but yet trying to write about these insulin cases or trying to talk about these insulin cases. It's a big intellectual challenge for me, given my GCSE level chemistry that I studied, unfortunately, how long ago was it now? 30 years ago? I think it would have been that I last studied chemistry, and it would have been at the GCSE level. So for me, it's an enormous intellectual challenge to discuss these cases and to understand all the information, and there's no way that I could do it on my own. So when I see the idiot brigade trying to write articles saying, oh yeah, what the experts said about the insulin is wrong, it's really quite laughable. So that's all I have to say for this video. I'm enormously grateful for the support I've received overall, but particularly for recent videos. It really helps if you like, comment, and subscribe to the channel. I'm going to stick to making videos every 3 days for the moment, but I may increase the frequency to making them every 2 days in the foreseeable future. But as always, if you have any queries, comments, observations, questions for me, corrections in particular, please do let me know. And thank you very much for watching.